Good night, everyone. I'm Professor Homer, and I'll be speaking to you tonight about general fertility. Just a bit about myself. I am one of 4 CREI accredited fertility subspecialists in Queensland. I am Queensland's first Professor of Reproductive Medicine. I direct the oocyte biology research lab, and I have my practice at Watkins Medical Center on 225 Wickham Terrace. Just a bit of background about fertility. Infertility affects about 1 in 6 couples in Australia. The distribution of causes of fertility are generally spread between problems with releasing an egg, which is ovulation, problems with the fallopian tubes, problems with sperm, and then a group in which all 3 of those tests are normal, and that's referred to as unexplained. In terms of how you diagnose infertility, pregnancy is a function of time. That is, the longer you've been trying, the more likely you are to get pregnant. But in general, 50% of couples will conceive by 6 months and about 80% by a year. After a year of trying, your chance of getting pregnant drops to very low levels, probably less than 2% after a year. So that's why the sort of limit of 1 year has come in for couples to seek help if they haven't been successful in that time. The impact of female age, however, is probably the most significant one that affects fertility success. And that really starts to take effect after age 35. And the reason female age is so important is that females are born with a fixed number of eggs, so that aging has 2 major effects on fertility. It causes a decline in egg number and a decline in egg quality. Because egg quality is the most important thing for pregnancy success, female age is therefore a major determinant of your overall chance of conceiving. So even when everything is completely normal, someone who is, say, 37 years old, this is the female age, has a pregnancy potential about half that of someone who is, say, 32. So for women over 36, there is a trend to encourage assistance even after trying for 6 months, largely because the window of opportunity is getting narrower. So that's a bit about general fertility. More specific components of it you can pick up in the history. Looking back on your own history, for example. The major sign of anovulation, which is not releasing an egg, is that periods are very erratic and are spread far apart, typically longer than 35 days. In terms of tubal infertility problems, so where there's tubal damage, some of the telltale signs that might be a factor are previous infection and previous pelvic surgery. And when I say infection, I'm referring to sexually transmitted infections, so things like chlamydia and gonorrhea. And the third one, which is Malefactor problems, we really typically identify that on a semen analysis. So perhaps the most important male test is a semen analysis or a sperm test. The results of the sperm test really depend upon how properly the sperm test is done. So if the test is done improperly, you'll get a falsely abnormal result. I'm just going to switch to some of the questions now. One question here is low AMH associated with higher rates of aneuploidy and miscarriage once pregnant? AMH stands for anti-Müllerian hormone, and it's produced by a particular group of follicles in the ovary. So it doesn't come from the egg itself, it comes from the cells surrounding the egg. AMH is not a marker of egg quality, and therefore it's not linked to aneuploidy, which is chromosome abnormalities, or miscarriage. It's a measure of egg number. When you're trying to conceive naturally, you're only ovulating one egg. So the number of eggs, the pool of eggs, the size of your pool in the ovary, which is what AMH measures, is irrelevant because you're only ovulating one egg. So what it comes down to is how good that one egg is. So that again is egg quality, and that is the only measure we have for egg quality right now. The best measure is female age. So that's a really important point for in terms of fertility, that AMH is not a measure of natural fertility potential. It's a test that's misused, especially in general practice, because it often comes back relatively low for age, and then there's a panic. But it is not a measure of natural fertility. This has been shown in very large population-based studies. Another question here: can taking the contraceptive pill for a long time affect future fertility? Not long term, but what does a major impact of the contraceptive pill is that it suppresses the transition of follicles into the antral follicle stage. And the antral follicles are the ones that can grow in response to hormones in the body to ultimately ovulate an egg. So women who come off the pill after they've been on it in particular for several years will find that their follicle count in the ovary that's visible on scan is falsely low, and as a result AMH levels can be falsely low. So the impact of long-term pill use on fertility is one that if you are trying to start an IVF cycle after coming off the pill, you may need to wait a few months for your antral follicle count to recover, because it's only antral follicles that have receptors to respond to the IVF drugs. The second important point about the pill and fertility, and something I see a fair amount of time, is that women who've been on the pill for a very long time, 10 to 15 years, from their teens, actually have no hint about whether their ovarian function is normal or not. And it happens quite rarely, but often enough, that women come off the pill only to realize that in fact their ovaries have already started to fail. So the pill, because it induces artificial periods, can mask a background a problem with ovarian function, which could be quite severe, including premature ovarian insufficiency. While we wait for some other questions to come in, I was speaking about semen analysis and that it needs to be done properly. So the semen analysis will measure three main parameters, which is concentration, that is how much sperm there is; motility, that is how the sperm are swimming; and shape, which is morphology. If there isn't adequate abstinence before the test, concentration will be low, and if the test isn't done soon enough after production, then sperm will start to die and motility will be falsely low. So semen analysis results are only as good as how carefully they've been performed. What else? In terms of investigations for infertility, one of the key starting points is the history. because you're always trying to assess those three parameters, which is ovulation, tubes, and sperm. And the key indicator, as I mentioned, of anovulation or failure to ovulate is infrequent periods, and 80% of that is caused by polycystic ovarian syndrome. PCOS is quite a complex multi-system phenomenon. The exact cause for it we don't really know quite clearly yet. But one thing we do know is that women who are predisposed to the PCOS phenotype will find it gets exacerbated by weight gain. And that's because it's linked to insulin resistance. And insulin resistance increases as you gain weight. So some women will find that initially their cycles are regular, indicating ovulation, but then as they gain weight, their cycles become infrequent. And conversely, that if you lose weight, your cycles can rectify themselves. So cycle regularity is really the key marker for ovulation. In terms of investigations for tubes, well, there's really the tests that we do seek to assess whether the tubes are patent, that is, whether they're open or not, whether dye can track from one end of the tube to the next. And there are probably three main ways you can test tubes. Maybe one of the commonest is with X-rays, and that's called hysterosalpingography. And that's done by X-ray departments. It lasts a few minutes and involves putting dye through the neck of the womb and then taking very rapid X-ray pictures. The other test involves ultrasound scanning, and that's called hycosi. Again, a contrast medium is inserted and it's tracked using ultrasound this time rather than X-ray. Perhaps the gold standard for testing tubes is laparoscopy, and you put methylene blue dye through the tubes via the neck of the womb. Laparoscopy allows you to see the tubes directly, so you can not only tell that they're open, but you can also tell that they have a natural, normal relationship with the ovary, because tubes need to actively sweep over the ovary to pick the eggs up. It's not a passive phenomenon. The eggs just don't miraculously drift into the tube. The tube has fingers at the end of it called fimbriae that actively collect the egg. There's significant limitations to the tube testing. It only tells you mostly if tubes are open, but really tubes do much more than just passively allow things to flow through them. The tube needs to move the fertilized egg back from the ovary into the womb, and that lasts something like 6 to 8 days. And in that time the embryo is dividing and will move from a single cell pronuclear stage embryo to form a blastocyst with over 300 cells. It's the blastocyst that enters the uterine cavity and implants in the lining. So this, raises an important point about fertility tests, and that is that they don't often give us the answers to the questions we are asking. So when we want to assess tubal function, really we want to know that the tube can do all these functions I just described, but in truth all the tests tell us is that dye can track from one end to the next. Similarly, with a semen analysis, oh sorry, I've been missing questions here. Can the removal of sorry, I'm going to go through these questions now. Can the removal of endometriosis actually improve egg quality? No, there isn't any good evidence that that's the case. It's difficult to understand how endometriotic spots in the pelvis is going to impact an egg in a follicle that is quite securely enclosed within the ovary. There's very little evidence that eggs that are sequestered in their own follicle is going to be influenced by endometriosis at other sites. It's only when endometriosis becomes very severe that it affects, for example, the vascularity within the ovary and overall blood flow, for example, to the ovary, that you can secondarily affect egg quality. But women who have endometriosis, we know, can produce very good quality embryos, which is the best marker of egg quality. So that is a very controversial thing. I know it's bandied about a lot, but the evidence that endometriosis impacts egg quality really is very poor. What age is it best to consider egg freezing? The younger the better. Egg freezing is, you have to think about, you want to make the most of your investment. And the best investment is a good number of good quality eggs. Quality being the key one. And the best time to have good quality eggs, well, the only time is when you're young. So if you're under 30, about 80% of your eggs will be good quality, whereas when you get to over 37, then the proportion of good quality ones drops to about 20 to 40%. So you want to freeze it when you have large numbers of good quality. The reason is the issues with egg quality are not only that you're freezing something good, but good eggs will survive the thaw well and will also fertilize well and form good embryos afterwards. What are the fertility options for men who have had a vasectomy? It depends on how long they've had the vasectomy for. The longer the vasectomy has been there, for especially more than 10 years, the lower the likelihood that reversal will allow normal sperm to enter the ejaculate. So another option, if there's probably the more commonly used one, if there's a vasectomy, is IVF, where sperm is surgically retrieved from the testis and then use that to fertilize the eggs in the lab. There's a question here, thoughts on letrozole. I'm not sure in what context, but letrozole's only use is in fertility is for ovulation induction. So it's used for women who don't ovulate, typically women with PCOS, so it's now recommended as a first-line choice above clomiphene citrate or Clomid for an ovulatory woman with PCOS. It's also used with superovulation, that is in women who ovulate already, in an attempt to get them to release more than one egg in combination with intrauterine insemination. So letrozole is an aromatase inhibitor. It's used in breast cancer, but it has the added effect of, by suppressing estrogen, FSH levels temporarily surge, and that gives you a boost of follicle growth. Is using your own versus using another's egg have any impact on pregnancy? The main impact it will have on pregnancy depends on the age of the egg. But in terms of compatibility between the donor egg and the recipient, there are no major issues there. The key thing is whether, for example, you're using eggs from a young donor, then your chance of success with those eggs will be much higher than from an older donor. So again, it's egg quality linked to female age. 30 years trying for 4 months, should we test sperm? I mean, there are rules about supposed rules, but it's usually in countries where everything is within the public sector. So, for example, in the UK, there needs to be statistical justification for doing tests that might cost the NHS. But if there's no harm in checking the sperm. Definitely no harm. I don't know if you're aware, but there was a huge study about 2 years ago that looked at sperm quality in men in the Western world, including Australia. And there was a 50% decline in counts in men from Australia, New Zealand, Europe, and the States over the last 40 years. So sperm problems are becoming very common. We think it's environmental. We don't know exactly what in the environment, likely a combination of things. So yes, sperm testing, I have a low threshold for doing that. It often enough throws up some surprising results. Because sperm will really will set the direction in your treatment. If sperm is very abnormal, your only option is IVF with ICSI. So very early on, I say your only option, well, your most successful option, that is. So it quite quickly sets you on your path of, which direction you're likely to be going in. During IVF, is it true that more eggs, the better the outcome? Absolutely. There's no doubt about that one. There was this thing going around for some time about mild stimulation is good. IVF is a numbers game, plain and simple. The more eggs you get, and that's been shown now by very large studies coming out of Spain, where they looked at over 12,000 cycles. I mean, it's not rocket science that the more eggs and embryos you get, the more. So the way IVF works, when I say it's a numbers game, if you ovulate one egg every month, everything is invested in this single egg. One chance, only one go every month. When you do IVF, if you get 12 eggs, it's like condensing 1 year into one go. Added to which you have choice. Now, the issue with IVF is that it's not 100% efficient, so that there's attrition at every step of the way. So if there's 12 follicles, you might get 10 eggs. Out of the 10 eggs, 8 might be mature. Of the 8, 6 might fertilize. Of those 6, you might get 3 good embryos, that is blastocysts. So you can see from starting high, you end up with quite a small but highly select group of very productive embryos. The more of those you get, the more chance of success you have out of a single cycle. So your cumulative chance from that single cycle is very high. So there's absolutely no doubt that more eggs, more chance of pregnancy. Interestingly, that fails to have any effect above the age of 44, and that's because above 44, so 45-year-olds and above, egg quality is so poor it doesn't matter how many eggs you get, the likelihood of getting a good embryo remains extremely low. It's never zero, but it becomes incredibly low. If an embryo is going okay at around 3 or 4 but then stalls, none to use, what are the reasons? That is an egg quality phenomenon. You see it very often with poor egg quality. And that transition, and you hit the nail on the head there, day 3 to 4 is the key transition for embryos, because that's when they're switching over from depending on maternal gene expression stored in the egg to driving their own gene expression. It's called embryonic gene activation. That's where they stall. That's the conversion from cleavage stage via morula into blastocysts. So poor eggs don't drive through that transition easily. So what you do is you transfer. Of course, you don't wait to blastocysts, because like I always tell patients, the one thing I can guarantee you in IVF is that if I don't transfer an embryo, you'll never get pregnant. So you want to transfer an embryo. Definitely you do. Because, like I said, no embryo, you definitely won't get pregnant. So for women who don't make that transition to blastocyst, the objective is undoubtedly cleavage stage and multiple embryos. The reason I say that is that your per embryo chance of pregnancy is low, so your multiple pregnancy rate is not high with multiple embryo transfer. But it does increase your chance that one will implant. Also, you have no comeback on a frozen embryo, so you really have to maximize your fresh embryo opportunity. How many follicles to aim for each IVF cycle? There's no limit really. The more the merrier. You want, like I said, IVF is about numbers. Now, what you also want is a fresh embryo transfer. So you want enough eggs that you get multiple embryos, but you also want a fresh transfer ideally. The reason I say that is because it depends on how good your lab is where you're at. But freezing and thawing subjects the embryo to trauma. And if the lab isn't very good, that trauma is increased. With a fresh transfer, obviously, there is no such trauma. But if you produce so many eggs, like typically happens with PCO women, then you may have to freeze all because of hyperstimulation. So there's this balance about driving hard for large egg numbers, but still getting to a fresh transfer and getting enough embryos to freeze. So that's where the skill in managing your cycle comes in. But in terms of numbers, it's thought that the sweet spot, if you like, for egg number is somewhere between 8 to 14. For me, it's definitely, I want to be in double figures, for sure. Because of that attrition in IVF as you go along. Okay, any more questions? All right, I think we might close off there for now. Thanks everyone for attending. I hope it's been informative. Good night.